Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everyone, and thank you for tuning in to this episode of the Doc Podcast. So as many of you know, my goal with this show is to provide the audience with a variety of guests to discuss topics that will not only improve on your personal, but your professional quality of life as well. Some of the episodes focus more on the personal side. Other guests, we talk more on the professional side. And still others, we discuss and dive into both of these areas. And with my guest today, Dr. Karen Parker Davidson, we are certainly going to fall into that latter or third category, discussing both of these areas. Karen is a renowned expert in the field of nasal function and rhinometry. We're going to talk a great deal today about the overall importance of nasal breathing and the consequences of mouth breathing, as well as how to accurately and objectively measure nasal breathing and then use that information to improve outcomes for patients suffering with breathing-related issues. To tell you more about Karen, she's an RN who holds a Doctor of Health Administration with a focus on health policy. She also has three master's degrees, one in administration, one in nursing, one in education. And she's, as if that's not enough, she's currently pursuing a PhD in business administration with an emphasis in international business. She's also a faculty member at Liberty University and Central Michigan University. Karen believes in the power of early intervention and the transformative impact it can have on one's quality of life, and has conducted extensive research into nasal function and breathing disorders. And this research, much of it has been published in various medical journals, magazines, books, and academic textbooks. And hot off the press, Karen just recently published her new book, Breathe Through Your Nose, Don't Pay Through It, the impact the healthcare industry has on nasal function and how we breathe. And I will be sure to put a link to that in the show notes for today's episode. Karen's overall goal is to inspire and empower healthcare providers and individuals to achieve optimal nasal function and overall wellness. And with that, I would like to extend a sincere welcome to Dr. Karen Parker Davidson. Karen, welcome to the show.
Good morning, and thank you so much for having me. It's a pleasure.
You're welcome. Thank you so much for being here. I didn't even touch this, just so everyone knows. If I read all that Karen has done and accomplished, we would probably take up half the episode, because she has done quite a bit of a lot of amazing achievements and accomplishments. She has a history in the Air Force and as a reservist in the Air Force. And so, can talk to me a little bit about your journey and how you went from kind of where you started in this decades back, to where you are today. What does that process look like, and kind of talk the audience through the evolution of who you are and what you do.
Yeah. So do we have an hour? I'm kidding. But
so this journey,
this journey began back in 1991. Please don't do the math. But I was at UNC Chapel Hill as a nurse extern in recovery room, thinking I wanted to be a nurse anesthetist. Well, if you know me, I can't sit still. I have the patience of a gnat. I'm always on the go. So that being said, I stayed in recovery room, graduated in 1992, went down to beautiful Charleston, South Carolina at MUSC, and I was their first ever new graduate nurse in the PACU.
Wow.
Got my CCRN in critical care. Then I went into the Air Force as a reserve flight nurse, transitioned to the vendor status in the medical device, where I thought, oh, this is cool. I could be a vendor and interacting with people in the OR whenever I would circulate. Worked in the ICU a lot. So all this was around airway. I mean, in the recovery room, that's where it really began, because I would literally have to go from the foot of the bed to the head in a matter of seconds in order to preserve an airway, because coming out of anesthesia, you have nausea, vomiting. And so that being said, I had some sick patients. I had to turn, suction, clear that airway. So then going into the ENT world in 2002, selling a vagus nerve stimulator, also with neurology. My biggest, I think my best memory was being at Johns Hopkins and working next to Dr. Ben Carson, me teaching Dr. Ben Carson how to put a vagus nerve stimulator in and how to
That's pretty
calibrate
cool.
it. That was cool.
Yeah.
But I jumped into the ENT world for about 8 years. So I've had the opportunity to see over 8,000 ENT procedures, surgeries, cadaver labs. And that's, I think, now I look back retrospectively. And I thought to myself, after coming into GM Instruments in 2017, like, what the heck? Nobody's looking at nasal function. What is this? So 2017 was that pivotal point, again, coming from GM Instruments, working in the ENT world. Then I worked in the HST, home sleep testing world.
Okay.
Helped small appliance companies do government contracting. Then here I am 7 years ago at GM. And I think that once I was like, rhino what? What's a rhinomanometer,
Right.
I couldn't even say the word, let alone understand, what this technology was.
Yep.
And I think that it was that point, bringing the product here to the States in 2017, that it really occurred to me as a clinician. Now I'm in, 25 years into being a clinician, thinking this is so needed, so powerful. Why are we not doing this? Why are we not measuring nasal flow, nasal function against a pressure gradient to see how someone is really breathing? Because again, we use the subjective questionnaires. I've used them in clinical practice. They're a great tool to really understand what brings the patient to your office today. They're valuable. It gives us a perception of their disease process, their symptoms. So the symptomatology is their description. The signs are what we see as a clinician. And we get that from these questionnaires. But in medicine, everything we do has a number. So I was in nurse practitioner school in 1995. And that's when I realized and learned the medical model. Do your exam, create a diagnosis, and give it a pill. And if you need a test for the diagnosis, but can't treat the test with a pill, then why do the test? Oh, let's throw insurance reimbursement in. So if the insurance company is not going to cover it, then do you really need to do the test? And we really emphasize those numbers. I mean, blood pressure medication. We don't do a blood pressure medication prescription without checking the blood pressure. We don't give a patient metformin or any type of insulin injection without checking the A1C or the glucose. So how does the airway differ? It doesn't. It's a
great point.
Yeah. So all these experiences since 1991 brought me to where I am now. And as my troops used to call me in the Air Force, the mouth from the South, I will talk to anybody. I will talk to anybody about airway function, aerodynamics. It's extremely important in the dental world that we look at this. I mean, it's important for medicine, but hello, orthodontists and dentists, y'all are in a driver's seat. We need you to measure, because through all of my research, and I still see patients and do clinic days for the breathing test, as I call it. And just a minimal 2 millimeters of tissue removal, tissue reduction can completely change the trajectory of the airflow. And like water, air follows the path of least resistance. And if, we have to do that. And what's interesting is that this whole nasal function, nasal resistance, it's cumulative. It's like a concussion. It's like year over year over year over year until we can't breathe anymore. So we have to really understand what's happening. Our volume in our nose does not equate to function. That's a big misnomer, because everyone does static measurements. Great tool, don't get me wrong. But those static measurements show us we have a way to breathe, not how we're breathing.
Interesting.
And that's where the 4-phase rhinomanometry comes into play. We have to see that motion of air. We have to see how much pressure is in the nose that's creating resistance, because it's that 3-second rule, that after 3 seconds, if you can't breathe, it needs an exit route, the emergency exit, like a plane. And that's the mouth.
Why? First off, thank you for explaining that. That's it's really interesting, people's journeys. I love hearing people's journeys because it's so, you didn't start in this. It's not like you were young and a young aspiring nurse and in your training, or when, you're standing next to a guy like, impressive figure like Dr. Ben Carson, and you're thinking, well, I'm going to go and figure out what this rhinomanometry is and nasal breathing. But you used your life experiences along the way and sensed that, and there was something burning in you that you had something to contribute to this, and you kept pursuing it, and you continue to keep pursuing it and learn, and educate. So why is this such a big deal? Why is nasal breathing, and I guess the converse of that would be not mouth breathing, why is this important? I mean, I've talked a lot about that. I know residents I teach and in my courses, people who have taken those might understand a lot of this, but I also have a lot of people listen to the show who are laypersons and just, moms and dads and have kids that might be struggling with breathing issues. And there's a lot of confusion out there as to why this is even important and relevant. And actually, I should say confusion in the medical and dental space as to why this is even relevant and important.
Yeah.
Though the science is not confusing and the evidence is not debatable. But talk to me a little bit more about why this is something you developed such a passion in, to make sure that people are breathing through their noses.
I think the passion derived from the deficiency that we were not looking at this objective measurement, which is so crucial, because you do a baseline measurement, and I have the mask here. It's just like this little simple mask.
Okay.
And you put it over the face. It's a 15-second test.
It it's like a computer, little, one of the CPR masks.
Almost, yeah, with the filter and the mask. And what is really cool is that within 15 seconds, just like that, we can pick up the breathing patterns. Are they erratic? Are they symmetrical? Are they, are the lines and the tracings, because there's 4 tracings during the test. Do those lines go on top of each other, or are they all over the place? We can look at tongue posture. We can see when there's mouth breathing. And what's interesting is that each level of nasal resistance, something physiologically happens. And that's how you're going to determine, is this person a CPAP responder or a non-responder? So at a certain level, when we breathe, and this test is done during active breathing in the awake state, no medications, sitting straight up, and it's addressing how you breathe during the day. Because a nose during the day is not the same nose at night.
What's different?
Yeah. And what's different is the recumbency. And this is all research. As soon as we hit 60 degrees lying back, resistance starts to increase.
Yep.
So you think of like Archie, Archie Bunker and the recliner and all of it. And you're like, all the men are snoring in the recliners on football Sunday. Yeah. And I was like, wait a minute, they're about 60 degrees reclined. Hello. The resistance starts to increase, and then they start to snore, depending on how much congestion. And conversely, when you're lying down and you come up 30 degrees, and this is what I tell patients who can't breathe, here's another simple thing you can do. Come up 30 degrees, because that's the pivotal point where nasal resistance begins to drop. And so to your question, the nose is a reactive organ. I call it its own little reactive organ. And we only see 30% of it on our face. And it's so important. It tells us danger. It even helps us pick our partners. It tells us, it brings back memories. And did you know that memories of perfume and cologne can take us back as far back as being 4 to 8 years old?
Wow.
I mean, that's how cool this nose is. So it's a reactive organ. It does 30 vital functions: humidification, filtering. You're absolutely. And what's interesting, it's so important that we nasal breathe. I mean, physiologically, and you see breath work, but the physiological aspect of it is 80% of our airflow to the lungs comes through the nose. And when you look at congestion and upper airway resistance, over 50% of upper airway resistance, which is the nose, the mouth that goes down to the trachea. So over 50% of that resistance and upper airway resistance comes from the nose. And 2/3 of the 50% happens right here in the first one into your nose.
In the nasal valve area.
And then absolutely. So there's 3 anatomical aspects that affect how well we take in air. That's the nasal valve area, the nasal cavum. And in the nasal valve area, there's two sections. There's external and internal before it even hits the turbinates. And then when you get to the inferior turbinate, that's the area where we have a lot of our allergic responses.
Yes, I can attest to that. as someone who's missing one of his inferior turbinates from a turbinectomy procedure I had as part of a FX surgery about 18 years ago that I had as an allergy sufferer. And I still deal with and suffer from, thankfully, not empty nose syndrome yet. Now that I'm in a more humid climate and warmer weather, I think that helps a lot. But it's a daily battle. I have to use a daily irrigation with a budesonide solution in it, to going through more immunotherapy and allergy shots. I mean, it's real. It's not easy. And when it impacts me, I mean, I went through decades of chronic sinusitis where I could not breathe through my nose. And who knows what that did in terms of my overall health and well-being. But I would notice too, I never had asthma or any pulmonary symptoms until I started all of a sudden mouth breathing all the time because I was obstructed through my nose. So next thing I know, with my allergies, I'm breathing in this unpurified air straight into my lungs, and it is not going through all those processes you just explained that the nose performs, all those functions. And anytime that I have more nasal obstruction and my allergies are bad, inflaming, as you said, inflaming those soft tissues and turbinate and the hypertrophy of the turbinates, I instantly start to get more bronchial symptoms. So the sort of pathophysiology.
It's a vicious cycle.
It's not, and that's exactly when I give a lecture on this. I literally call it the vicious. Nose breathing begets nose breathing, mouth breathing begets mouth breathing, and it's a vicious cycle you get in. And then to take that a step further, which I won't go into in detail now, but I then teach the side of, once you are in that vicious cycle of the mouth breathing, then you have the ramifications of transverse deficiency and insufficient tongue space and all of the sequelae that come down the road. And it really, I think the important thing that you said is this, it's like, it all starts with the nose. It's so overlooked. I mean, it's probably the most prominent things on our faces, but it is often overlooked how much of a role this plays. So I think a lot of people here, and I actually put myself in that category, to be honest. I never learned about this in school. I had phenomenal training in orthodontics and biomechanics, but we didn't talk about the nose and what the nose does. To this day, most orthodontic residents and certainly dental school students are not learning anything about nasal breathing and nasal respiratory processes and the importance of it. And I would venture to say that I think a lot of us overlook it, and we then overlook why we need to even be talking about it or concerned about it. So if you would take a little bit of time now to say, okay, if we could all, let's just kind of wishful thinking that we're all on the same page that this is so important, right? I don't know why some don't believe that, but that's there. That's true. So let's just say everybody understands, okay, it's essential that we do this. How do you have this dynamic measurement? And again, just give a little background. A lot of us have cone rooms in our offices where we're looking at these static measurements, and you can, as you said, glean a lot of information you can gather a lot of information from the nasal volume. And I mean, obviously if you have insane turbinate hypertrophy and obstruction, right there, you're not going to be able to get air through and no patency. But some are like a gray area. I shouldn't use that word because we're talking about radiopacity and lucency. Some are, I guess, literally a gray area. Little radiology joke there for those of us that look at these things. But there's an area where I would have some patients come in, and they would report on their questionnaires or in my questions for them and their parents that they're mouth breathing, maybe snoring, and then you look at them, and their nasal passageways certainly didn't seem to be obstructed. They didn't have any overt lymphoid tissue obstruction. Right. They are not breathing well through their noses. So am I on the right track that's sort of this next level of this, that why one patient with pretty decent obstruction might actually be able to breathe through their nose, and one patient with minimal obstruction can't? Do you see that? I want to take a moment to thank the sponsor of today's episode, Retainers for Life. We all know how stressful in-house retainer fabrication and replacement can be, especially during those busy summer months. And that's why you need to check out Retainers for Life. Retainers for Life is an affordable and convenient retainer replacement program that not only fabricates custom retainers for your patients, but they actually deliver the new retainers directly to your patient's doorstep. And the best part is that you, the doctor, get to maintain control over the retainer design and material, set your own fees, and generate additional revenue for your practice. Plus, as a very satisfied customer of Retainers for Life, I can honestly say that the entire team is truly amazing and will be there to assist you and your team from onboarding to implementation. So go to afterorthorevenue.com and schedule to book a discovery call now with a Retainers for Life team member. And be sure to use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Again, that's afterorthorevenue.com. Use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Trust me, you won't be disappointed.
Yeah, absolutely. Yeah. So I'm going to go back to your point about the academia aspect of this.
Yeah.
So rhinomanometry has been around. The concept has been around since 1895.
Oh, wow. 1895.
Yeah. And then in 1966, Dr. Claus Vogt brought, rhinomanometry, like the computerized rhinomanometry, to the forefront. And Dr. Maurice Cottle maneuver,
yep.
he brought rhinomanometry to rhinology.
Okay.
So 2 years ago, and I'll get to my point, but about 2 years ago through LinkedIn, Dr. Vogt said, I'm the father of rhinomanometry. I see you're the VP of GM Instruments, full disclosure. Do you think we should work together? So fast forward, he's now 88 years old. He said, I'm old and I need to pass on all of my work to somebody, a legacy, and I choose you. Wow. Whoa, big shoes. So my office is literally a history of nasal function.
Wow, how fascinating. That's really cool.
And what's really cool, so here's the connection. So Dr. Vogt, he was connected through an associate of Dr. Christian Guilleminault.
Okay. Yep.
Dr. Christian Guilleminault in 1989 was invited to speak at Riga. Now, also Dr. Vogt wrote the International Standardization Committee guidelines for objective measurement. So there is method to the madness. So Dr. Christian Guilleminault is invited to Riga to do a talk. He said, I will not go unless I meet and talk to Claus Vogt. So they formed a friendship. And Dr. Vogt made his own little special rhinomanometer, 4-phase rhinomanometer for Dr. Guilleminault. So the papers that you see about 4-phase rhinomanometry from Rhinolab is Dr. Vogt's company, his product, and his special device that he made for Dr. Guilleminault. They became longtime friends. Yeah, he says, oh yeah, I'd come to the US and we'd have red wine together. It's like a history trip. But so to your point, when we look at academia, I didn't learn this in nursing school, nurse practitioner school when I started that. And I did switch over to the, still a master's, still advanced practice nurse, but I chose the clinical nurse specialist role, which is more healthcare education, so on and so forth. So a little bit different role. But we are 40 years behind in America. And when I encounter some of the ENT guys that I knew from years ago, from 20 years ago, I say, hey, do you do rhinomanometry? Oh, it's for research. Oh, it's not valid. And they're thinking back to the very first one that came out in 1992. So there is some truth. There is an original rhinomanometer that came out in 1992. Dr. Vogt did some research. And then he created the 4-phase rhinomanometry. He did over 36,000 tests and found what the patients were saying as far as their symptomatology correlated to what he was finding on the rhinomanometry data output.
Okay.
Now, that's a whole other conversation as far as the output, because it tells us so much. Then shortly thereafter, he's like, what are these crazy loops? What is happening on the tracing, on the graph? And that was a nasal valve phenomenon. So to your point, why does someone look congested versus not congested, but still can't breathe? And that's because over 30% or around 30% of the population has what's called some form of a nasal valve phenomenon. Meaning, when you look at the aerodynamics of airflow into the nose, it's called the Bernoulli's principle. We look at velocity and how the air is getting that little tiny space.
The lift on airplanes, right? The same principle.
Great analogy. That's in my book, chapter 3. How nasal function is like flying a plane. But when you look at the aerodynamics, even when you use nasal dilator strips, any manipulation in this first 1 inch will redirect the air, recreate the aerodynamics, and possibly cause higher resistance.
And just completely counterintuitive to what you would think.
Exactly. And I'm doing a study now, and I'm doing it with athletes. Very, very interesting. So if you don't have a severe collapse, does a dilator work? Well, yes. And there's 3 phases. There's a minor and a moderate and a severe collapse. So how does that play a role? And we have to understand, we can't see nasal resistance. We can't see it with the scope. We can't see it on an image. So what you see on an image, again, shows you we have a way to breathe, but it does not show the air of motion. And
that's such a great point, because like we think about this in terms of turbulence in arteries and getting a catheter done to be able to look at the blood flow through vessels, and we can see it. Like you can see it's you can see blood, obviously. You can't see air, and I that's such an understated point and phenomenon that people, I think, until you just said it, I'm like, wait a minute. I think that makes it so hard to quantify. We have all these parameters on what we think is happening, but just like when the plane takes off, you can't see that air flowing over the wings in that concept of the Bernoulli's principle. It just is there, right? If it was liquid or water, you certainly would see it. And I think Bernoulli's was started as liquid, and then they said because air, right? Air, I don't want to quote me exactly, but I think it was something of a liquid principle, fluid dynamics, but then it applied to air because of the lumen size.
Yeah. And so we're stuck in this mindset, through our training. Again, rhinomanometry, now 4-phase rhinomanometry is very popular in the EU, China, the UK.
Oh, is it? Okay.
Oh, yeah. And what's ironic is,
are they using it? Use? Okay.
Yeah. Oh, yeah. If you Google rhinomanometry, you will see so many studies in China. And also Dr. Guilleminault, this is interesting. When I asked Dr. Vogt, I said, well, why did he do more studies here? But there was a lot of old school thought, it's not valid or repeatable or anything like that. He did a lot of his work in Taiwan. Where they were using it. He went where he was welcomed, right? So it's like I go where I am welcomed to teach this. But it's really interesting. And when we can't see resistance, we can't see the pressure changes, we really lose the art of breathing. There is no art without the motion of air. And that's just plain and simple. We can't change it. But what Dr. Vogt and I created and defined this year, just recently published a few months ago, was functional rhinology. So we have created a new subset to ENT and dentistry and orthodontics called functional rhinology. And we incorporated what's called rhinopathia, nose disorders. So rhinopathia, endotyping, phenotyping, and even genotyping. I know what? We use endotyping and phenotyping in sleep all the time. Well, now, Dr. Hoel in 2023 had a study published that we can look at the physical attributes of someone's face. Like in 30 seconds, I can tell you what side of resistance and possibly how high that might be. And you can definitely see an OSA face is completely different than a non-OSA face. And I have that data.
I teach residents all the time when I show these cases, trying to train their mind and their eyes. And number one, not to just look straight to the teeth, because my goodness, that is still what we're teaching in the majority of our training programs, is to number one, just step back and look at the patient's face. And Bill Harrell and I talked a lot about that on our episode when he was on the podcast, but looking at the face, analyzing the face. But then when you do that, starting to just be able to look at these, in this case, pediatric faces that we're talking about, and just maybe is there an airway issue here? Start to recognize some of these things before you even look at the radiographs and the clinical side of things, because you're 110% right. There is a distinct phenotype and a distinct look that you can have to these patients when they do present with breathing issues. And on that, can you extrapolate a little bit, since this might be a good time to segue into this part of it?
Yeah.
Measurement and determination of the impact of mouth breathing, called sleep apnea, sleep disordered breathing, sleep related breathing disorders, right? There's all sorts of different names for them. But the inability of our diagnostic parameters, especially AHI, the apnea hypopnea index, to quantify the exact and translate to the exact magnitude and existence of, and if it exists, magnitude of the diseased state. And I feel like this is a really important area to dive into a little bit, because what you're doing is, I mean, we haven't even met here. We're talking about sleep and breathing and airway and all of these things. And we haven't even talked about obstructive sleep apnea necessarily, or the apnea hypopnea index. I've talked on the show a lot about the certain flaws with that. I'd love to hear your thoughts on.
Oh gosh, where do I start?
where that index misleads us and misguides us, and why we have to be so careful, which sadly, a lot of the literature, especially in the orthodontic and dental arena, and even in the medical side, they focus so much on OSA, right? It's all about, well, hey, look, if you did this and it didn't change obstructive sleep apnea. So let's just break that down for now, if we can, just on the pediatric side. When we're talking about younger kids, and it can be, anywhere from 3-4 years old up to, say, 8 or 9, kind of that pre-adolescent range. When you have a child that age, is AHI a good indicator of disease? If you see these, okay.
So I'm going to tell you, I'm going to give you a few little phrases from the book, little quotes. So I did these little quotes of my own opinion and takeaways. We will have a nasal dysfunction before we have a disorder. I'm going to repeat that again.
I say, please repeat that.
We will have a nasal dysfunction before we have a disorder. We have to breathe well in order to sleep well. If you're not breathing well, you will never sleep well. And that's why Dr. Vogt.
And breathing well would be breathing through your nose.
Exactly. Breathing through your nose.
Right. Okay.
Exactly. And a few things. So Dr. Vogt, he coined the term rhinopathia nocturna, sleepy nose. And you can see that in supine, there is an increase in nasal resistance that is healthy, that is acceptable. But when we don't see a change in resistance measurements from sitting to supine, that's our cue that that's an OSA patient.
Say that again. I want people to hear that. I wasn't aware of that.
Yeah. So we can see from sitting to supine, there is a natural increase in nasal resistance. But if we don't see a change of about 20% or so from sitting to supine, that's a key indicator of OSA.
Interesting. Okay.
So if they're resistant when they're sitting, holy moly, they're suffocating when they sleep.
Got it.
And another key point, and I go bananas about this. People are like, quiet breathing, no resistance. No, people, we need resistance. We need a certain level of resistance when we breathe that slows the air down over the cilia for filtration, through the turbinates for humidification, moistening and warming the air. And it should go up over the olfactory cleft. We need resistance. Airflow to the airway is like the pH to our blood.
But if it was a tube, it wouldn't get into our sinuses where the nitric oxide is residing to be purified. I mean, that's a great point. Like just having this tube that it went straight through the nose, it would not have all the benefits that it has.
Right. And there is a sweet spot. There is a sweet spot for nasal resistance. There's a normal range. But yeah, so if we have no resistance, we have what's called empty nose syndrome.
There you go. Yep.
And we're a negative pressure circuit breather anyway.
Yep.
But when we can't breathe and we feel like we can't catch our air, we become a positive pressure breather. Well, we're not frogs on a lily pad gasping for air like that. We need resistance to slow that air down. And I also, when we look at sleep disorder breathing, I will tell you today, that term drives me crazy. Why? Because our sleep I call it breathing disorders at sleep, because again, we're gonna have a breathing issue before we sleep.
Got it.
And and the thing is, I appreciate sleep medicine, don't get me wrong. But if you look at social media, if you look at academia, everything is sleep, sleep, sleep. I wrote an op-ed and I sent it to Wall Street Journal. It was reviewed, but I didn't get picked. And in that, I said, everything is, sleep apps, sleep apnea, sleep courses, sleep podcasts, sleep books, sleep, sleep, sleep. I'm like, we focus so much on 1/3 of our day. We forget about the other 2/3 of our day.
Interesting. Yeah. Yeah.
When we're walking around.
Yep.
And we don't walk around with CPAP during the day.
Right. Right.
We only use it at night. So if we focus on our daytime breathing, our daytime measurements, then that could improve our sleep portion. So in children, I'll tell you a funny story. I was working for an HST company, sitting in an in-service, and they were talking about AHI. And I said, wait a minute. And I raised my hand. I said, so let me get this straight. We are going to help someone breathe when they stop breathing. We're going to wait all that time till they can't breathe to help them breathe. I said, AHI, apnea, hypopnea index. That's the dumbest thing I ever heard of. And everybody turned around in the course and looked at me. I said, yeah, I said it.
Yeah.
I said it. And that was back in 2012. 2012. I said, AHI is the dumbest thing ever. And I was thinking from my critical care nursing background, because our patients on the ventilator, here's the physiology. When the nose is dysfunctional, we will have a nasal flow limitation. We can't get air in. That flow decreases. Then we have an increase in pressures in the nose and the back of the throat. Then we drop our oxygen level. So we have the hypopnea. Then we we have like the pressure changes we can't respond to. Then we become hypoxic, and then we wake up. So there is a cycle, and I have it on my Instagram page. There's that cycle, that continuum of what happens. We don't go from nasal breathing to sleep apnea overnight.
Right.
That takes a long time to show up.
And the fact that it has to be greater than 10 seconds for these episodes to occur. So it's like, I was always miffed by that. I'm like, so like if it's 9, like, they're good, like no disease here. I mean, that's really what the criteria are saying, essentially. Like if a child goes in, and I saw many times where a child didn't register as having any deficiencies on a sleep study, yet this kid had all the indicators and signs and symptoms of someone with a sleep-related breathing disorder of some capacity. And I'm going, what is going on here? Which is why I stopped relying on polysomnography in the sleep tests for the ultimate determination of whether or not this child was suffering from some sort of sleep-related breathing disorder, because it was not able to be specific enough and determine what was actually happening. And that's, again, to tie it into the academia and the research. They hold on to that AHI, that AHI scale, and whether or not they had a diagnosis of OSA as the barometer and the threshold for all things related to sleep and breathing problems. It's like, well, and just the mere fact that the pediatric sympathetic nervous system is more active and they get stimulated more easily, so they awaken more quickly. I mean, I've said this before, but I want to repeat for those who haven't heard it, but the pediatric apnea-hypopnea index for determination of obstructive sleep apnea is an extrapolated scale from the adult data. It is not done on studies, data, research. It is literally taken from the adults. That's why the levels are like 1/3. It's not an accident. It's like, wow, that was really coincidental that it all was like 1/3. No, it literally was extrapolated, knowing that the overall pediatric conditions and their actual nervous systems are different at that age. And I'm not faulting the people who made that and who were involved in that process.
Right.
It's just an evolution of thought and ideas. And we have to now look at that and say, okay, that was a good step back then, decades past. It gave us you got to start somewhere. You got to have some sort of quantifier to say, like, what's going on here? Now that we know better, we need to do better. And I think that's what you're saying, as I'm interpreting it, is no, this is so multifactorial. This is so multifaceted. There are so many things going on here, even beyond just sleep. There is, like, this kid is not able to breathe. That's a great point. So what are they doing in gym class, right? Maybe they're not able to run well. Maybe they're not able to keep up with other people. No one even talks about that part of it. If this kid can't breathe through their nose and oxygenate properly, maybe this kid is developing asthma, right? Maybe this kid has frequent bronchitis, especially in the colder weather climate. So all of these things that spawn off of what you're talking about here, I think are things that we need to push academia to say, look, you need to look at this. Like, you need to start to do more research and evidence-based. Actually, I want to talk about the evidence-based side. So I mentioned in last week's episode with Stacey Ochoa, I want to hear, and what you're saying is right in line with it. And not that I have any relationship to or promotion of Peter Attia. I don't know if you know, but he wrote the book Outlive, and he talks about the three stages of medicine, and medicine 1.0 being like Hippocrates and bloodletting and all of that, where you just kind of tried to figure out, like, there was stuff happening and you thought it was the gods doing it, and you just kind of were like reactive.
Yeah.
Like, how can we like make this? And sometimes it worked and sometimes it didn't. You caught up with him, or, whatever it was, and you try to figure it out. And then medicine 2.0 was kind of that next stage where we started to have like Lister and Pasteur and start to understand a little bit more about the microbial nature of things, and bacteria and viruses and sterility, and then antibiotics. And we kind of had that sort of evolution through the 1800s and 1900s of treating disease, right? We started to recognize, okay, we're defining disease and then we're treating disease. And the problem that he goes into with that is, and he's calling us to go to medicine 3.0, which is exactly what you're talking about, which is go into a proactive pre-disease analysis. Don't wait until the patient has diabetes. Don't wait until the patient has cardiovascular disease. Don't wait until the patient has cancer. What can we do? Don't wait until they have a neurocognitive deficit. Those are what he calls his four horsemen. Those are like the four big things. And sleep-related breathing disorders, obstructive sleep apnea have all been proven to have implications in all of those arenas. So if we know that one of the sort of comorbidities or precursors to a lot of these major health crises that we're facing are related to our ability to have restful, deep REM sleep, and we know that there are certain anatomic variables that impact this, why in the heck are we waiting until these people are 40, 50, 60 years old and need a CPAP and some type of surgical procedure to try to fix this, right?
Yeah. Well, and that's why you have me.
Yes, that's why I wanted to have you on. I mean, you think in that way, and I want to pick your brain on that stuff because I love the way you think on this.
And I say this with humility, but Dr. Vogt and I are only the two global experts that really understand this, and so I'm trying desperately to get the message out.
Is it hard? Is it hard to get it out?
Yeah, I'm one person. Do you know how many? I mean, there's like 15 million practitioners in the world.
Yeah.
That's a lot of talks. Yeah. I'm getting there. And before we change habits, we have to have acceptance. People just, I think a lot of the old school doctors, and I've worked with some really good ones and some really, I don't know about you, kind of doctors. And I think we have to have that open mind, because if you look at Europe now, Dr. Welker-Borsky did a study that was published in 2023 as well. And he found with reliability, predictability, repeatability, that children can be measured with 4-phase rhinomanometry as young as 3 years old.
Wow.
Now, in the dental world, you begin to see those oral changes around 2 to 3 years old, as far as teeth crowding and things like that. And now, October 28th, 2023, there was a huge press release that in Europe, they are emphasizing in children's hospitals to measure every child with rhinomanometry.
Really?
So here in the States, if it was truly an interest, and again, we are not a healthcare system. We are a disease management system. And I can't say that enough.
Yes.
We're not, we're taught, I was taught, like I said, a nurse practitioner school that first semester, nurse practitioners, there was about 71% of us that work independently. So we're a great reference source. But our approach is a jingle that I remember from that first professor, and it was prevention, early intervention. But that's not the medical model. Remember, assess, diagnose, give it a pill.
Yep.
And we're so driven by disease management versus, preventative care.
Or a surgery, a pill or a surgery, or both.
Yeah, surgery. It's like beeline to the surgeon. And what's interesting is that in my doctoral program, when we looked at, global healthcare systems, we had to write a paper to say, okay, there's all the systems in the world. Pick two to your choosing, and write a paper why those two should come to the US. So I picked the UK National Health System and the Taiwanese. the Taiwanese health system really emphasizes, exercise, nutrition, and things like that, preventative care that we can take control of and stop eating so many preserved foods and just nonsense foods. I mean, we're basically eating chemicals out of a bag.
Oh my gosh, don't get me started.
Another conversation.
Yeah, right. Well, I have to have you back on. We're going to dive into that again. Oh, man.
Where in the UK, they started primary care. And then kind of like an HMO here, you go to your primary care and then you're referred up to the specialist at different levels.
Okay.
So people say, well, Karen, why is it, rhinomanometry here? And I said, it's a great concept. And if it was actual and factual, there would be a 4-phase rhinomanometer at every pediatric physician's office and every dental office. Because here's why. You can expand, again, look at that structure and expand till the cows come home. Oh, the AHI is this. And they're looking at the end stage of nasal dysfunction to manage a current situation. So we're in this reactive state of managing care versus being proactive.
Yep.
And I think this is where the screening, and everyone loves questionnaires. Again, they're a great piece of the puzzle for that subjective data. But we have to understand that what you see on a scan, Pascal's law, to the fourth power and this and that, that's gone. Sorry, folks, it's gone. Now we work with the Weber-Feichner law. So we're looking at the psychophysics of breathing. Because what the patient feels and how they determine or understand that current situation is far different from their response to the stimuli. So I'll repeat that again. The Weber-Feichner law is, how your body is reacting to a stimuli, breathing, versus how you interpret that sensation. And the only way we can differentiate that, because I have patients come to my office, oh, I can nasal breathe. And I'm looking right at them. No, you can't. Have a seat. Let's measure you. And then when I show them and I here's your tracings, here's your study and your test, and like, whoa, what's that mean? You have moderate obstruction. And I said, and I'll ask them, when was your last sleep study? Oh, it was 6 months ago. Congratulations. You are the proud recipient of a future diagnosis of moderate OSA. What? Because that amount of resistance, that amount of flow limitation is going to march you down the road. And even though we may not be able to pick up an AHI in 5 to 10 years, do something now. And there's a sweet spot on the graph. If you see on that sweet spot, upper airway resistance, jump in, do something now. But here's the caveat. What you think is helping expansion may not be working, or it works to a point. Also, a mandibular advancement device. They're big in the market. I see them all over the social media.
Sure.
And I hate to be the bearer of bad news. There's a study, and it showed that even though the pharyngeal area was being increased, volume, there is a sweet spot as far as nasal resistance. So when you manipulate the mandible, 1, 2, 3 millimeters, and you get to that 50% effective phase where it's working, from baseline to the 50% effective phase, nasal resistance will drop by 23%. Yay, it's working. Good tongue volume, good pharyngeal space, so on and so forth. But if you were to go to that targeted of 75% protrusion, guess what? Nasal resistance increases. It goes from baseline to that 75% target, and you increase resistance by 46%.
Wow.
You are now creating a sleep apnea patient or a future sinus surgery patient. Because also when you expand, our little maxillary sinuses are kind of like the shape of a pyramid. But as you expand, those sinuses change a shape, right? If you block that ostia, the meatuses, and there's no way to drain the sinuses, now you've created a sinus infection patient in the future who's going to need sinus surgery. And the sad thing is that within 1 year, and this is all of my research that I did for my health policy dissertation and my first doctorate, patients that have sinus surgery, we know that 20% of them are not candidates. And we also know that the revision rate, and this is at that time I was doing my study, it may be higher, but the revision rate for sinus surgery is 12% within 1 year. 12% of patients that have sinus surgery will have to have surgery again within 1 year. And there's no guarantee it's going to work.
That's the thing that is so interesting about this is I feel like we're kind of just like throwing darts at this. And no one
exactly
right with our treatment modalities. We're literally our diagnostics. We don't even really have the best sense of what's happening right with the sleep studies, and some are getting better at incorporating RERAs and overall mobility of the patients, hyperactivity during sleep cycles.
Yeah.
But if we just are looking at AHI, which again people still call polysomnography AHI the gold standard for adults, I don't know that you can, it's even really been proven in literature to be the case for the kids, although we still tend to use it as such, especially people who oppose any sort of approach of the orthodontist or dentist in the airway arena love to say, oh, no, you can't even deal with AHI. You don't even, there's a letter to the editor back in December, an AGODO, and this gentleman was talking about like, if you want to deal with airway, go be a physician. I mean, come on, like, okay, so we're just supposed to put our head in the sand and ignore this. And I say a lot of times I feel bad for people like that because he clearly has never had the experience of helping a young child the way I have, and the ability to go in and help these kiddos thrive and do better by looking at their nasal passageways and getting them to the allergist and or ENT and doing growth modification, correcting the transverse deficiencies, helping the protrusion of the mandible, all of those things we can do. He clearly hasn't had that benefit of a parent breaking down in tears in his office saying, nobody cared until you. No one paid attention. I knew something was wrong with my kid. I knew that it wasn't just that they had ADHD or that there was something else going on here. And now that's all gone, all because the orthodontist took the time to figure out that there was something more going on with them and didn't just look at their teeth for their teeth, but looked at it for the fact that, well, why are these teeth so crowded? Why are your jaws so narrow? And, John, at 7, like you should have more room for your tongue than this. There's more going on. And look at the dark circles under your eyes and look at the obstruction in your nasal passageways or the overgrowth of your lymphoid tissue or the tongue collapsing backward, even though it's on a static image of a cone beam. You can see that tongue postured posteriorly and that narrow oropharyngeal airway and all of these things that I could go through in less than 5 minutes with parents and explain it all to them. It's not rocket science. It's very easy to see and explain, and then get them to the correct medical professionals, and then go in and perform my evidence-based treatment, which is to grow and develop the arches to a normal width. And when you do that, not in all of these kids, and I think that's again where the rhinometry and so many of these other things come into play, using the rhinomanometry to maybe figure out in those kids that didn't respond, which was not a ton, but they are there. And I had that happen. And those kids might show nothing on a sleep study, some of them. And those kids would be bouncing back and forth from the allergist to the ENT. And I'm looking at it going, they're plenty wide. I've made the transverse, right? And I've gotten the growth and development of the craniofacial complex to be normalized. Something else is going on here. And so it's multifaceted, it's multi-tiered, it's multi-layered. Everyone needs to do a bit of ego checking and be like, okay, I get maybe we didn't learn this. I get maybe this isn't exactly how I've been practicing or been taught. But maybe there's a place to just step back and open our minds a little bit and say, maybe there's more going on here than we really know about. And all of us working together instead of being so siloed and in our own little worlds. I found, I've been very open about this, and I always preface it with, I don't mean to make this as a disparaging remark of my orthodontic colleagues. I love my field and my profession. I just try to call balls and strikes on this. And the sort of the feeling that like you shouldn't even be dealing with this. The orthodontist and the dentist should stick to straightening teeth. And I've had very high up people in different organizations in our profession tell me the orthodontist job is to straighten teeth, not to be concerned with any of this. So what do you say to those people? Hey everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
Ooh, where do I start? Do we have another hour? So I respectfully and diplomatically say that's a stupid thing to say, but in my head, I'm like, that was a dumb thing to say. Here's the deal. When you look at, again, even the slightest movement in any type of skeletal structure soft tissue components, anything you do, dentist, orthodontist, any shifting you do by a few millimeters is going to change the trajectory of the airflow because it's coming through the nose. And guess what? That flow also affects the retroglossal and retropalatal pressure changes. And how that flow and how that pressure is coming through will change the way the structures respond. So I probably won't make many friends and I'll probably get dropped off a Christmas card list, but OSA is not a collapse. It's not a tooth collapse. It is a pressure flow relationship. It is the pressure changes and how the structures are responding. And they usually use the P-crit. So if the nasal pressure is really higher than the tracheal pressure, there's collapse. When it's flipped, the air flows. And that's we have to look at the physics of breathing. We have to, and the aerodynamics, because that plays so much of a role. So to the naysayers that say, this is experimental, it's research. It's not. It's rhinomanometry is published in over 2,000 papers. It's highly published. And it's a simple test that we can do on these little children and what I recommend to dentists and orthodontists, always get a baseline. Know what your starting point is.
Yep.
Within that first month, look, because I've had MSCs have from high resistance to normal within 21 days. No lie, I've got the scans and I've got the tracings to show it. So also in my research, looking at rhinomanometry in kids, what I'm finding is that tooth positioners or like MyoBrace or the guide or all these different type of tooth positioners they use in early children does have an effect. I've got the proof. Like within 2 to 3 months, we see a change where the resistance drops. But there's other variables we have to look at as well. So we can go beyond the AHI. Even in adults, I've seen, I've tested patients like, ooh, that's like moderate to severe OSA. And I'm like, I just had a veteran, PTSD with night terrors. And we could fix the night terrors, but there was something going on with the breathing. He said, I had one 3 months ago. And my AHI was 0, no sleep apnea. And I said, what? I have to remember that nasal resistance is very slow, very sneaky, and very insidious. And over the years, we just don't look at it. But if we could really look at those changes early on, we could do earlier interventions. So again, anything structural we're going to do with these kids, we have to look at how that movement of the skeletal structure, because nasal function will determine your skeletal structure. And I can see it in faces, and that's why I created the Maverick. Maverick nasal exam. If you would. Yeah. So being a military girl, everything to me is an acronym. And I was getting ready to do a talk for AAPMD last September. And I'm thinking, okay, midline, asymmetry, nasal valve issues. I'm like, Maverick. So it's proprietary, but there are certain things to look for. And what I teach providers that within 30 seconds, you know what you're going to deal with. And all I need is 2 pictures of somebody. And I can tell you exactly what side, potentially how severe, and the nasal valve involvement. And again, a lot of what's happening, in orthodontics and dentistry may or may not affect that nasal valve area. And again, Dr. Vogt and I have a new concept in airway called elastometry. So we're looking now at the lateral nasal walls and how strong those are, because that's going to play a role. So if we look at nasal resistance, the structure components, the bone and the mucosa play a role. But now we have to look at the outside, the lateral nasal walls. How strong are they? How thick are they? How much collagen? And we can measure this. We created a device where we can measure this. So it's so multifactorial. Yeah. That's why I say the nose is so complex.
Yeah.
But I think that, and I've always been conservative in my practice. Anything I've done, I'm like very conservative. I look at allergies, diet, the environment of that child. Then I do a nasal spray. I always use xylitol. homeopathic. I don't like Flonase, no offense. I don't like Afrin because of the rebound effect, and it could give you a false test, you know. But I look at, is there a mucosal membrane component? And we can tell in rhinomanometry, is it structural, bone, or is it an actual mucosal problem, or is it a nasal valve issue? So we have to really, drill down and get to that root cause. And then we go into, you can do this test with a device in the mouth. What does that device do in place during the test? So I think the biggest deficit beyond that was all of this data. And I had somebody say, okay, Karen, you've been doing this for 4 years. You don't have interpretation. We don't know what this data means. What do you mean a breathing pattern? What's resistance? What's it do? And that's why I created Daphne. So I wrote the software, which now goes into Airway AI. So the data's up in a cloud. I can pull the data of all the measurements that are entered into Daphne, and then look at the pattern the pattern repetition and recognition. Is a 40-year-old do well in this device because the resistance drop? Is this CPAP machine better than this CPAP machine? And so now that becomes artificial intelligence and airway, nasal airway management.
Interesting. Yeah,
did I answer your question? I was kind of going down a rabbit hole.
You absolutely did. And I think one thing I would say to kind of summarize that is, I think a lot of it is just what you just explained. It's just too complicated for most to want to deal with right now. And I think, in other words, what you're doing a great job trying to distill it and create ways for us to digest this and incorporate it into our practices. But Stacey Ochoa and I were talking about this in last week's episode. Ultimately, when you're busy in your practice and you're doing what you're doing, like let's say as an orthodontist especially, I mean, to stop and say, okay, I'm going to have to now learn this technology, invest in it,
exactly
how to implement it. And then now that I figure it out, okay, great. Now I've got most orthodontists, and this is a whole separate conversation, aren't seeing kids at 3, 4, 5. They're saying, let's say I'm seeing at 6, 7, 8 when they first come in a lot of times. Now I've got to figure out, what do I do with this information? What does this mean? Am I now increasing my liability, which is what everybody sadly thinks about, right? Can I build?
Ooh, good point.
Another thing everybody thinks about, right? So it's much easier to just put your head in the sand and be like, that's quackery. There's no place for that in orthodontics. You know why I think a lot of people say it? Because they don't want it to have a place in orthodontics. Truthfully, because it's like the headache that it incorporates. And I'm not even being critical of people. I'm not even faulting them for that. Like, I get it. I've run a practice that's been slam busy with tons of staff. The challenges associated with that. The last thing you want to think about a lot of times is changing and transforming the way you. And then when you transform your diagnostics, like when I incorporated my cone beam 10 years ago, you then have to transform your treatment approach, because now you're like, well, now that I know this, I can't treat this way. I can't do that because I know this. So I've got to do this. And it has this cascade effect that I think intimidates a lot of people. It's fear. Fear can be a powerful thing to make us dig in and have tunnel vision and be very myopic for the fear of what knowing more will result in. So I think you explained it perfectly. And that is, this is complicated. And right now you're working on it, but there aren't these great, easy, I'll call it quantifiers to be like, oh, I put this device on, they do this, that means this, number one. And number two, once they have that information, which it sounds like we're getting closer to, what the heck do they do about it? How do they even manage this? I mean, is it at that point, do they need to change their orthodontic plan? Do they need to work with their medical colleagues? So again, not problems that you or I can all solve here, but I think it's just important to bring to everyone's awareness. Like, this is, and it's almost, I'm not making excuses for these people not doing it, but I think it's important to just look at the psychology of this and say, this is a lot for people. And especially, we didn't learn any of this. Like, we didn't learn this in school. So, I think a lot of it has to come from the parents, from being driven from podcasts like this and your book and things that we're doing to try to educate on people on it.
I want to tell you one thing. I want to tell you one thing real quick. So in the orthodontic world, anything you're dealing with as far as a skeletal, what's really important to understand is that there, on the genotype portion, we have 4 genes that dictate and play a critical role in the relationship of our facial features, like the width and the shape of our nose, as well as even how pointy it is. And those 4, I had to write them down: DCHS2, RUNX2, GL13, and PAX1. those are those 4 genes that we all have that play a role in our nose. So if you have children with the genetic deficiencies, like in Downs, for example, where they have more of a flat bridge of the nose, that's going to play a role. That's why that structure and that observation and understand the genetic component also plays a role. But also PRDM16, that's found in our little nasal septums, and that plays a role in oral facial development. So if there is a genetic deficiency with that gene involved, hello, oral facial deficiencies.
Wow.
There and you go.
We can be screening for these things. Knowing. I mean, there's so many ways that we could be looking more into this, right? I mean, then now again, it's what you're saying is what I was saying with Peter Attia. It's medicine 3.0. It's that next level of like, before they are this suffering sleep apneic patient, right? With all these other comorbidities, how can we figure this out ahead of time to stop them from getting there? And I guess I look at it as, why wouldn't the orthodontist want to play a role? I know we're busy and straightening teeth is great. And I love doing that. That being said, when I started changing patients' lives by understanding this stuff more, not even at the level you're talking about, just again, in my cone beam and clinical diagnostics and seeing the symptoms and symptomatology of this and working with my medical colleagues and helping these patients grow. I mean, I say this all the time. If you're out there, reach out to me. I'll have you on the show. You can prove me wrong. I've never met anybody who started doing this, became more airway aware as an orthodontist or dentist providing orthodontics, and had this impact on patients and their families, and was like, I don't want to do this anymore. I don't think this is worthwhile. I want to stop doing this. I want to go back to just focusing on the teeth. In fact, it's quite the opposite. I find almost everybody who I've trained, coach, learn from me, learn from others, there's many ways out there now to learn more about this stuff, has the exact opposite attitude. And that is, holy cow, how come I didn't know about this sooner? And how can I do more of this? And I think that speaks volumes, right? I mean, ultimately, if this wasn't something that had such a profound impact on people like myself, I wouldn't be fighting so hard for it. I mean, if I started doing this and I was like, well, I'm not making any difference in these kids' lives, why the heck would I be trying to push people to learn more about this, right? And there's different modalities on how you're going to treat. I'm not even saying you have to do it a certain way and use this device versus that device, but heck, just be aware of this stuff and just be cognizant of it and try to follow things like rhinomanometry and what that means and where that's going, and look at more of these diagnostic indicators and start to critically analyze the old data that go so much into the OSA as the end all be all, right? Just start to be more aware of this stuff and not be so obstinate that we play no role in this. I mean, do we really want to diminish our value?
Well, I'm going to share 2 quick stories with you before we close out. So you mentioned Dr. Harrell. So I taught Dr. Bill Harrell rhinomanometry. He's got Daphne. He's got the peak nasal respiratory fluid textbook
coming up too, right? Don't you?
I have 2 chapters. Nice. 2 chapters, not 1 but 2.
I'm excited.
And I'm speaking, and next week I'm speaking at the American Dental Association Pediatric Airway Consortium. So awesome. I'm doing 2 talks, and I'm talking about nasal resistance as a new vital sign.
Perfect. Well, this will go out right. What's the date of that meeting?
It's next week.
Perfect. This episode's going to be launching like 2 days before that, so that'll be awesome.
Yay! So, what's interesting is that Bill's like, Karen, I need some help on, reading, what's going on here. I'm like, great. So they FaceTime me, and the mom is in the back of the room in the corner. I'm on FaceTime, like looking at the actual tracing. I'm watching the rhinomanometry test. I'm like, okay, here's my interpretation. Deviate septum, erratic breathing patterns, da, 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 da. And the mom in the background said, can she see my daughter? Dr. Bill said, no, she's watching the tracings. She's watching your daughter breathe against the pressure gradient. Mom said, she's scary. Because I physically defined her daughter and described it by defining what was happening on that on that nasal flow and function test. And I'm really passionate about this because there's a lot of talk about ADHD. This goes back to my brief but very important time in children's mental health when I was in North Dakota. And I worked under a federal grant, and I get a little emotional, so grab a tissue. But all of those children, I case managed from 3 to 13, and I look back Not one of those kids had a sleep study done. Fast forward, and this should not take another parent 8 years, 8 years to discover what I found. And it was in 2000. So my son was born in 2006. And when he was in 2A of Montessori school, that was like around 2008, they mentioned things about his speech, like his speech wasn't adequate enough. And he would get ear infections, but he didn't meet that threshold for PE tubes or the pressure equalization tubes. He would get, 5 infections and then no more. Then he goes to kindergarten. He's disruptive. He can't focus. He needs an ADHD test. And I did a few of the Vanderbilt questionnaires later on, like in 4th and 5th grade, but everyone complained he's not focused. He needs go to the pediatrician and get him a pill. And after working in children's mental health, I'm like, heck no, I'm not going to do that. There's something going on.
Right.
It's 2nd grade. I heard that snore. And now I look back, I'm like, the chapped lips, the shiners, and the teeth crowded. Because I thought.
What I teach, you got it. Yep.
I thought baby teeth all straightened was perfect in a child. No, they should look like a picket fence. No one told us that. And he went to the dentist early on. I took him in when he was about 1.5 years to 2 years old. Fast forward, I heard that snore, and I'm like, that's not normal. I knew the snore was not normal. And I said, come here, kid. And I said, show me the back of your throat. He has 4+ tonsils. This kid was suffocating. So I called my favorite ENT that I'd worked, with as a vendor. And I called him on the cell phone. I'm like, Gail, yes. Do you still do coblation, which is a technology they use for tonsillectomies? I'm like, you still doing coblation? Yep. Can I have an OR day next week? Sure. So we went in, did the pre-op, did everything, got the tonsils out, got the adenoids out. Then in 5th grade, we found out his dental age was 3 years behind. So even though he was 10, dentition age was like 7. So we go to the orthodontist. I love my orthodontist. And we did a quad helix self-activated expander. And he started excelling in baseball. Now, Zach's played baseball since he was 3. He hit his first grand slam. He was like 10, playing in 11U baseball. And then in 8th grade, we started Invisalign. Now, it's interesting. And now he's a catcher. His pop time now.
That was my position.
So his pop time, and I'm going to toot my horn for this guy. His pop time is now 1.84.
Wow.
He's 6 feet tall, and I just love him. But, I look back and I'm thinking, dang. And I played the commoner with the pediatrician. I didn't tell him that I was, an advanced practice nurse. I didn't tell him anything about my background. Had I not listened to my heart and really paid attention, I would have been bamboozled right through the medical system. Now, we did try a few medications and he felt like a zombie, and it affected his sleep. And I just did a talk last Friday and I said, not one mental health disorder is without a sleep problem. But yet we give these children a stimulant. Got to get back to the airway. But we also have to look at dopamine levels, because that can play a role in the ADHD, as well as the development of the hippocampus, however you pronounce it, and wish to, and the amygdala. So there's so many variables in ADHD that we just can't rush to judgment and give them a pill. If I did that, my son would not be where he is now.
And how many kids are your son at that age and aren't where they could be?
Well, no, but if you look at the CDC statistics, I think it's 5.1 million children between the ages of 4 and 17 are diagnosed with ADHD. And I misspoke. I said 67%, but it's now 69% of those 5.1 million children are on a medication. Wow. And guess what? Not one of them had a sleep study or their nasal function tested, their breathing tested, nothing. And how do I know? Because I would be getting calls from doctors to get help to interpret the results. They would be calling me saying, Dr. Karen, what does the data mean? And I do that. I take calls. I get text messages. Help, give me a quick interpretation. What's going on here? I'm happy to do that. But So, you look at that, 69% of the kids out of 5.1 million ages 4 to 17 are on medications.
And I mean, it's so frustrating. And
that's a whole nother show, right?
Yeah, seriously. And I can kind of ending it on that story that brings it all full circle is really appropriate for what we talked about today. And that is, yes, we can talk about rhinomanometry and acoustic rhinometry and cone beam, CBCT, and all of the, DICE and studying people with polysomnography and all these fancy words, right? At the end of that is a person and a human being, right? It's a child in the case of your son and what I in my practice. And I believe it is incumbent upon us as healthcare providers, to not put our heads in the sand on this, to not just say, I didn't learn about that. That must be quackery because I never was taught that. And if it wasn't something I was taught in all my years of education, then it can't be.
No, or it's for research only. There's no reimbursement.
There's no, and say, if that's your kid, how can you not want better for that child? And the fact that there are so many, what's your son's name?
Zach.
There are so many Zachs that I saw. I mean, when you were describing him, Karen, I was like, oh my gosh, like I saw so many Zachs walk into my office at 7, 8 years of age, and I would look at their tonsils and look at their lymphoid tissue and airway, and I would have that exact conversation with a parent. And I had multiple times that a mom, especially, would literally break down in tears in the consult room when I would start saying, and a lot of those kids were on ADHD medication. And we're not saying that every ADD or ADHD is sleep related. What we're saying is there's a lot of them out there and we don't know which
exactly.
And we're just throwing meds at these kids because of their symptoms instead of looking at their etiology. And we're not saying that every orthodontist or dentist can solve ADHD. There's obviously, as you said, neurologic components that go beyond just what we can do and see.
Right.
You can recognize if that patient is presenting with reports of ADHD and they have obstructive lymphoid tissue and obstructed nasal passageways and transverse deficiencies and no room for the tongue and all of these things. Well, heck, isn't it incumbent upon us to say, let's get these things addressed. Let's get them to the ENT. Let's get them to the allergist. Let's go in early interceptively with orthodontics and help them grow and help them develop. And then if after that, right, we've normalized everything as much as we can and used all of our diagnostic ability and treatment ability to do it, and they still have a problem, well, okay, I don't know that the orthodontist is going to help much with that, just to be honest. At this point, maybe in the future we can, but right now, it's kind of using all our tools and abilities. How can you stop shy of that and sleep at night? Like, how could you literally, knowing there's a Zach out there, to my colleagues, how can you, and message me if you want to come on and talk about this, defend your stance that you don't think you should have a role in this, but how can you know that you could do something? There's a lot of orthodontists that are going to die on that hill to say no orthodontist should do anything related to airway. You literally focus on the teeth and the teeth alone.
But that's the problem. Those teeth are like little neurological antennas.
Yes.
And they affect the trigeminal nerve to the mesocephalic nuclei that affects nasal resistance. Oh, you can't breathe. But I want to tell you, there is hope. I have the first psychiatrist in the world in Hawaii that are now doing 4-phase rhinomanometry, partnering with orthodontists. And one of my favorite people from my COVID research that I do with this other group, Dr. Hamza Paracha, love him. He's an incredible mind. He's a psychiatry resident. And his department chair, who was double board certified in neurology and psychiatry, I proposed a retrospective study to look at like a tooth positioner. It was the guide, it was the Vivos guide, because that's the data I had. And here's what's really cool. We were the first to show that you can treat two pathologies at the same time to diminish or completely resolve the behaviors and symptoms within 3 to 4 months with early intervention in children ages 5 to 12. And that was the first dental paper published in a attention deficit psychiatric journal. But, Dr. Escobar in 2018 hypothesized that maybe these earlier oral appliances or tooth positioners in children could help with ADHD-like behaviors. And guess what? They do.
Yeah. I saw it all the time. And I think it's really, I love to end that on that positive note and that's not just being, sort of Pollyanna, like, it's all good. No, there's challenges. We've got a lot of work to do, but you know what? I said this in last week's episode to Stacy, I feel the pendulum starting to shift. I feel like people are starting to see this new paradigm, and I have a lot of hope in this new generation. I think their empathy and their understanding of the overall bigger picture of things, as much as we joke with them about it and kind of laugh about it, as it makes them, kind of that woo-woo-ish, like, no, there's something in them that wants to be a little more that medicine 3.0. Like, let's stop this before it gets too bad, right? Let's not just let everything devolve to the point that we're playing catch up and trying to figure out how to put all the pieces back together. And I really do have a lot of hope. And as I've been doing this for not that long of a period of time, I did it in private practice almost 20 years. I've only been doing this publicly for less than a year at this point. And already the people I have contacting me and the people that I've spoken with and the meetings I've spoken at and the groups I've lectured to and the positive feedback, it's like there is a movement going on here, and we are going to win this. I really do believe that. And there's so many kids out there, so many Zachs out there that need us to win this. We'll win it. It's just we have to keep getting the message out. We've got to keep educating, especially the parents. And if you're a parent listening to this, trust your instincts, like Karen did. Believe that there's that, and take your child. Don't stop until you message me, message Karen. We'll put our emails in the show notes. Try to keep finding answers to rule out that it's not something that's being overlooked by sort of the modern traditional model.
And we're getting there. Remember, any change in medicine, and to the defense of the orthodontists and dentists, remember, I brought 4-phase rhinomanometry over to the US in 2017. First introduced it, just showed it to somebody in dentistry in 2018, and then in orthodontics in 2019. And it takes about 12 years for a new concept or new something in medicine to really take place. Well, guess what? We're in the dental and orthodontic world. We're only 4 years in, 5 years in. We're not even halfway there, but I'm making progress. Yeah, that's
we'll
get there.
Yeah,
absolutely.
We will get there. Yeah, and anything
you got the mouth from the south, right?
Yeah, keep fighting, and well, I really enjoyed this. Went a little longer than I planned. I apologize. Thank you for your time that you gave to me and to the.
Oh, what a pleasure! I told you, give me an extra hour.
And I will. We're going to have you back. At some point. We've got so much to go into that I didn't get to that I want to ask you. And you're just such a wealth of knowledge on this, and I'm learning on this. And I know the people out there listening to this heard a lot of things that they've never even heard before. And even if they don't agree with it all now, just start looking into this. Just be aware of this, and just the raising of awareness that we're doing in this. And your book out there, get Karen's book, focus on this. Start to be more aware of what we're looking for in our patients, understanding the physics of breathing and what this all involves. And then together we can all find the solutions that will really help get ahead of this and stop so much disease and end state disease from happening.
And even for the children, to help them understand how cool it is to nasal breathe. I have a new children's book coming out in June. It's
cool.
Series. Yeah, it's a series called My Little Nose. And the first book, it started out to be a dedication to Zach. And I thought, I want one for little girls. So there's a book with illustrations for little girls, and there's a book for illustrations for little boys. Same wording, just, one for boys, one for girls. And that book is called My Little Nose, Where the Air Goes.
Oh, I love it.
So if all goes well with the printer, it'll be out towards the end of June.
Oh, please let me know when that's out as well. That's so cool.
Okay.
And thank you for doing all this. And I mean, it's what you do and what you're doing. I don't know how you have the time and energy to be doing this many things regarding it, but I appreciate it. And I thank you so much for being on. And
it's a pleasure. It's a pleasure. And I'm happy to take any questions. If somebody contacts you, I say this lightly, but use my brain. Everything I've gathered over these 33 years of clinical practice and experiences, I'm happy to help. I talk to parents all the time through Instagram. On Instagram, I have posts. My handle is @_the nose knows, KNOWS.
Okay.
So the nose knows.
To that too in the show. And I agree. I echo that. Reach out to me. I'm happy to have people ask me whatever questions. That's how we learn and grow. And I love that. I have people, literally, there's not an episode I do that people don't reach out to me with some sort of question or follow up. And I love it. That means that we're starting to get people thinking differently, right? We're
making noise.
We're making noise. They're questioning it, good, bad, and different. You're not going to hurt my feelings. You're really not. So, even if it's something to be questioning or doubtful, I welcome it, because that's ultimately how we grow and how we all learn.
Exactly.
Well, thank you so much.
It's been a pleasure. Thank you so very much.
Stuff. Really appreciate it. All right. Take care.
Take care. Bye-bye.
Bye. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. And remember to join the doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.